to order. Can I have legal counsel report on the proceedings of closed session, please?
Certainly. Thank you, Madam Chair. The board considered 6 items in closed session this afternoon. The first was a conference with real property negotiator. And I'd refer you to the agenda for the particular parcels. There was no reportable action. Second was a liability claim. The board voted 5-0 to reject the presentation of a late claim of Rod Giarducci against the Tahoe Forest Hospital District related to a medical malpractice claim. Third and fourth were hearings under Health and Safety Code 32155. There's no reportable action. Fifth, the closed session minutes of February 24th were approved, 5-0. And lastly, medical staff credentialing, the recommended credentialing decisions were also approved on a 5-0 vote. And that concludes my report.
Thank you very much. Item 9, deletions or corrections to the posted agenda.
Chair Wong, staff requests that resolution 2022-08, agenda item 16.2, be moved up on the agenda to follow acknowledgements.
Okay, so we will be moving that item 6.2 up to 12. Okay.
Thank you.
All right. Any other deletions or corrections? Then I'll open it up for audience input. And this is an opportunity for members of the public to address the board on items which are not on the agenda. If you wish to give a comment, please raise your hand or use the icon on the bottom of the Zoom screen to be recognized, and I'll call upon you to speak. When addressing the board, please state your name for the record, and then your comments are limited to 3 minutes. I do apologize in advance if I have to have you wrap it up. Written comments can also be submitted, and they can be submitted to the board's clerk 24 hours prior to the meeting to allow for distribution. And then under the Brown Act, it's known that we cannot take action on anything that's not agendized. But as a board chair, I can choose to refer the matter to staff or have it agendized for later discussion if it's warranted. So with that introduction, do I have anybody in the audience that wants to have input on anything not on the agenda? Okay, I don't see any hands. Have we had any written comments, Martina?
We have not received any written public comments.
Well, with that, I'll go ahead and close audience input, move to employee association input. So if there's any member of our association, please raise your hand if you wish to speak. Judy, you're raising your hand. Is there anybody in any written comments, please?
No written comments from the employee associations either.
Okay, so then we'll go ahead and close input from the Employees Association and move on to acknowledgements. Our first acknowledgement is for Doctor's Day, which is March the 30th, 2022. And Mary Brown, our director, will give us an acknowledgement.
Yes, great. Thank you. It's always been an honor for me to, when Alice asked me to give this, to read this acknowledgement, because it gives me a chance to give a little bit of a wink and a nod to many of the physicians who have been in my family and my life, starting with my 3 great uncles and my grandfather, my 2 uncles, and my father. My beloved father, who was a very distinguished physician in San Francisco and who would be 100 years old tomorrow. So this is a very special acknowledgement for me to read. And as Alice said, tomorrow is March 30th is National Doctors Day. And Tahoe Forest Health System proudly celebrates the local physician community for their commitment, sacrifice, and hard work. On this day, we recognize the diverse and valuable work doctors perform, from primary care and specialty care to urgent and emergency care. National Doctors Day is a special opportunity to personally thank and recognize the dedicated men and women who keep our community healthy and save lives. Interestingly, National Doctors Day was first observed in 1933 and was officially made a day of celebration by President George H.W. Bush in 1991. This particular day was specifically chosen because it marks the anniversary of the first use of ether anesthesia by Dr. Crawford W. Wong. So please join the health system in recognizing and honoring the physicians on March 30th, National Doctors Day. I can't believe it's just a day. I think we should honor them every day, but March 30th will be the day.
Are there any other comments about Doctor's Day? I'd like to make one, and what I want to do is to wish the best to Dr. Rick Ganong. He has spent 44 years with us on Doctor's Day, and my understanding is that he's retired, but has not resigned. So we may not be seeing him around, but I do want to extend our best wishes as he moves into retirement. So moving on to another acknowledgement, we have Harry Weiss, and he will do our resolution 2022-08.
Good evening, Chair and members of the Board of Directors and our team and the public. It's my great pleasure to share this resolution this evening, and it's a resolution to celebrate Judy Newland and her 42 years of service to the Truckee Tahoe region and Tahoe Forest Hospital District. It says, whereas the Tahoe Forest Hospital District is a hospital district duly organized and existing under the local healthcare district law of the state of California, and whereas the Board of Directors wishes to recognize Chief Operating Officer Judy Newland for 42 years of dedication, passionate, and loyal service to the district, and whereas Judy Newland was hired by the Tahoe Forest Hospital District on December 27, 1979 as a nurse for the emergency department, and was soon transferred to the position of paramedic liaison nurse, and 1 year later assisted as the acting ER coordinator. And whereas in 1984 was a busy year for Judy, becoming the ambulance manager in February, acting ER manager in July, and then earning the official position of ER manager. And whereas on July 1, 1995, Judy elevated to the Director of Emergency Department, a position she held for 6.5 years before serving as the Interim Director of Quality and Regulation Services, and officially becoming the Director in the department in September 2001, a position she held for nearly 10 years. And whereas on May 28, 2011, Judy Newland assumed the role of Director of Nursing at Incline Village Community Hospital, which in less than a month, she became the Director of Nursing and Operations, followed by ascension to Director of Operations and Chief Nursing Officer in November. And whereas in July 2013, Judy became Chief Nursing Officer for Tahoe Forest Hospital District, and in addition, elevated to Administrator of Incline Village Community Hospital. And whereas Judy Newland became Chief Operating Officer for Tahoe Forest Hospital District on June 13, 2016, where she demonstrated exemplary leadership, commitment, and during COVID-19 pandemic crisis management, innovation, and perseverance. And now, therefore, be it resolved that the Board of Directors of Tahoe Forest Hospital District hereby thanks Judy Newland on behalf of a grateful community for her commitment and service to the district, and employees, and above all, to the patients we serve and wishes her all the best in her next station in life and travels.
Yay, Judy.
Well, now you know why I'm retiring. Wow, I didn't remember all of that.
No wonder you're exhausted.
Yeah.
Yeah, wow. Wow. Harry, thank you so much. And to the board of directors, thank you so much for this resolution. You know, so yeah, 42 years ago, I think I started on night shift in the emergency room. And I guess next Friday, April 1st, I will be walking out of this organization. And I will tell you, I'll have a lot of great memories and really appreciation for all the people I have worked with. This is an amazing organization, and the opportunities that this organization has given me for my career growth, which I think you've heard, but also all the friendships that will remain intact. And, you know, when I look back, I really just think about how thankful I am to have been with an organization that really serves our community, and the caring and all of the kindness we give to our patients and visitors. You know, when our employees walk through those doors every day, they think about the impact they have on the patients and the visitors. And we work as a team to provide that care. And I'll have to be honest, I absolutely feel privileged and honored to be able to have worked for this health system. And Harry, thank you again, and to the board of directors, thank you for this resolution. It was very meaningful. And I have to tell you, I'm actually shocked by all the different timelines you have. I knew I did a lot of different things, but I feel so fortunate. So thank you all very much. It's been a joy.
Oh, Judy, thank you. What a legacy you've left at Tahoe Forest. I think you've been the real role model for nurses coming up. That nursing isn't just the bedside, that you provide patient care over so many positions, and that there's opportunities for everything that you want to do within the healthcare system, within nursing, within, you know, all the things that we can do. So thank you again for all the work and the love you have put into our organization.
Thank you very much. Thank you all.
Enjoy your vacation, and thank your friends for getting you on.
Thank you.
Zoom.
You're sitting in the room. You talk about awkward. So.
Okay, well, enjoy your vacation.
Yeah.
And then we'll
Thank
move
you.
on
Thank you.
to item 13.
I just have just a point of order.
Oh, sorry.
It would be nice if the board would actually make a motion, a second, and maybe pass the resolution.
Thank you. Thank you for reminding me to do that. So can I have a motion to approve the resolution 2022 honoring Judy Newland's retirement as Chief Operations Officer for the district?
I would love to make the motion.
And I would love to say,
Okay, so it's been moved by Director Brown, seconded by Director Shamlin, that we approve the resolution honoring Judy Newland. A roll call vote.
Director Barnett?
oh, you're muted, Bob. There you go.
Muted? Hello?
Now you got it.
Big yes.
Big yes.
Director Shamblin?
Yes.
Director McGarry?
Yes.
Director Brown?
Absolutely.
And Director Wong?
Absolutely.
Thank you all. That was very thoughtful. Thank you. And I appreciate it.
Okay. Now moving on to item 13, the Med-Exec Committee meeting consent agenda. And Dr. Lane, you have the microphone.
Thank you. Dorothy, do you want to put up a slide, or do you want me just to start going? Okay, so the Med-Exec, we met on March 17. We approved a neurology privilege form, and this is to accommodate our new teleneurology service, which will be Blue Sky Neurology. and they've updated the teleneurology and telestroke. And then this has been vetted by Dr. Kreis and Dr. Abby Young, who is one of the emergency docs director at Incline, who's been really key in bringing in this much needed valuable service. And so this just delineates what their privileges are and how it works out. And it's all fairly standard, but already vetted and then also accepted by the Department of Medicine, and MEC accepted that. And then we had some policies with very minor changes, clinical privileges that cross specialty lines. So it discusses if you're in one specialty and you want privileges in another, how would you go about obtaining it? And it really just says you got to go through MEC, and here's a brief. This is how you would get privileges in somewhere other than your own specialty, and that will be considered. And then the next one was on computerized physician order entry, CPOE, and this just delineates the strong push by the hospital to make sure that physicians or nurse practitioners or PAs are entering almost all of their own orders or most of their own orders, and we're trying to get away from verbal orders, and it's a push for that. And then the last one is on the HIPAA confidentiality, and I believe this one just added the risk statement at the beginning, but otherwise we stay with the same HIPAA confidentiality that we've had. And then the last one was the critical access services, and this just, there's no changes in this, and it just delineates all the services that Tahoe Forest offers and what the hospital has, emergency medicine, obstetrics, all of our inpatient, outpatient services that we offer. And there was no changes to that form. Can I answer any questions?
From the board?
So this was a fairly non-controversial set of policies that we passed.
Are there any questions from our audience? Hearing none, can I have a motion to approve the Medical Executive Committee consent agenda as presented?
So moved, Dale.
Second, Michael.
So it's been moved by Director Shamlin, second by Director McGarry, that we approve the Medical Exec Committee consent agenda as presented. A roll call vote.
Director Barnett?
Yes.
Director Shamblin?
Yes.
Director McGarry?
Yes.
Director Brown?
Yes. Yes. Yes.
Director Wong?
Yes. So, Dr. Lane, the MEC consent agenda has been approved as presented.
Thank you.
Moving on to 14, the consent calendar. And these usually are reports or are usually routine and non-controversial, but any member of the board or staff can pull any of these items. Once they're pulled, then we will put them later in the meeting under item 17. So are there any items that an individual wants to pull?
Chair Wong, I would like to pull agenda item 16, agenda item 14.6.1 for a brief discussion at the end of the meeting.
Okay, so we will pull that particular item, and that again is 14.6.1. Any other items to be pulled from the consent calendar? If not, can I have a vote to approve the consent calendar without the item 14.6.1?
And if any member of the public wanted to comment on the consent agenda, they could do so now.
Thank you. Is there anybody from the audience that wants, or from the staff that wants to pull a consent item, or any comments from the audience? Okay, so again, can I have a motion to accept the consent calendar with the exception of item 14.6.1?
So moved, Alice.
A second?
I'll second it. That's Director Barnett.
It's been moved by Director Brown, seconded by Director Barnett, to approve the consent calendar with the elimination of 14.6.1. A roll call vote.
Director Barnett,
Yes.
Director Shamblin,
Yes.
Director McGeary,
Yes.
Director Brown,
Yes?
Director Wong.
Yes. So the consent calendar, except for the one item, has been approved. We'll move on to 15. And we have with us today Brian Montanez from Multnomah Group, who will tell us about the annual, or the retirement plan, the semi-annual update. So Brian?
Yes, good evening. Thank you for having me today.
Okay.
As I mentioned at the last meeting, we have some very good news to share about the activities of the committee over the prior 2 quarters. So on the screen, you'll see the summary of the Q3, and then we'll talk about Q4. And as I mentioned last time we met, we did our annual fee benchmarking study in Q2. And the first bullet talks to the fact that the committee considered the fees and considered the last time they had done a market search or competitive bidding process for record-keeping and administrative services, and elected to go out to search to explore the market. We didn't necessarily have any problems with Fidelity. We were just following what a prudent fiduciaries would do and periodically survey the market. The committee's plan-related goals were best-in-class operational and compliance support for the administration of the plan. Robust and easy-to-use participant plan sponsor web tools, including state-of-the-art education, savings analysis, plan demographic reporting, an effective employee education communication days, effective employee communication and education program, including fiduciary advice to the participants, and at least 5 days annually of on-site education support, and a dedicated service team to work with the committee at our committee meetings. After discussing with my firm, we elected to send it to 4 record keepers: Fidelity, who was the incumbent, Empower, Transamerica, and ICMA. If you don't know who ICMA is, because it's not a household name, they specialize in governmental plans. The committee reviewed, additionally, the committee reviewed the investments, and we did have one fund that was on the watch list, and that was Fidelity Managed Income portfolio. It is a more conservative fund, but the expenses were above average, and the majority of the underperformance was due to the high fees. When we had higher interest rates, fees were less of a portion of the portfolio's returns. Given the low return that we've been in for the past couple of years, it became a problem. Martina, next slide, please. So at the Q4 meeting, I presented our analysis of the vendors' responses. We looked at the organizational strengths, client service model, education and communication tools, the technology used to operate the plan. Of course, we wanted an open architecture investment, not willing to give up any particular asset class at the expense of the other participants, and the proposed fees. After considering our analysis and discussing with the committee, we invited Empower, Fidelity, and Mission Square to present on December 6th. And poor committee, they had to deal with me for an entire day. We did discuss the vendors' proposals, team members, the proposed team members, the backgrounds of the team members, the fees, the conversion requirements, and the value we thought that was brought to the participants. And after thorough consideration, we elected to continue with Fidelity, but at a reduced rate. And as you'll see here, prior to the RFP, the participants paid 0.16, which we did not consider to be an abnormally high fee. And at the using the December 31 estimate, that was $208,000. Because of the competitive fee process, we were able to get 208 reduced to 116,000, a 44% reduction in participant fees. We made another change to the model and how we pay fees. Instead of having fees paid based on your percentage of assets, we were able to negotiate a per head fee per plan, so $45 per plan. So someone in both plans will pay a fixed fee of $90. So as assets increase, that participant's account fees will not increase, and the service burden incurred by Fidelity is directly tied to the number of participants that they serve. This is something we try to work with clients when we get to north of $100,000 account balance. And if you were following the ERISA lawsuits over the last 4, 5, 6 years, I guess 6, 7, 8 years now, many of the settlements are including moving from a pro rata or asset-based fee to a per head fixed participant fee. So we were able to move to a more contemporary model that ties the services to revenue and reduce fees by 44% for participants. We also agreed to change the Fidelity Managed Income portfolio and move it to the to the T-Row Stable Value Price Fund. We evaluated the comparable credit qualities, the liquidity provisions, the fees, and simply T-Row had a comparable credit quality with a higher crediting rate. We were able to actually improve this asset class's return by 0.72% above the other product. Next slide, please. Oh, thank you, Martina. So a breakdown of the plan using December 31 numbers, and as we all know, these are very different now. But starting in the top left-hand corner, we have the 401A plan, the employer contributory plan. Plan assets increased from $62.3 million to $66.7 over the 6 months ending December 31. And we did remove the stable value product, and all the other investments remained satisfactory. On the top right-hand corner, we have the 457B. Those assets increased from 78.3 to 82.6 over the 6 months ending December. The investments are the same, and some real positive news here. Participation rate increased from 83.4 to 83.9. So automatic enrollment and HR are doing a great job there. And the average deferral rate increased from 9.3% to 10%. That is a big jump. And again, I'm going to credit auto enrollment. And you put the two together, and the total savings rate, which is employee and employer. Now keep in mind, most financial professionals want to see people saving between 10 and 15%. Yours has gone from 13.9 to 14.3%. Those numbers indicate that the average participant in the Title IV retirement plans is very adequately saving for retirement. Does the committee have any questions?
I'm sure Judy Newland will appreciate your report as she's had her investments. So any comments or questions for Brian regarding our retirement fund? Any questions or comments from our audience? Well, we thank you again, Brian. This was just a presentation for discussion. So thank you again for your presentation.
All right. Thank you for your time and have a lovely day, everybody. Bye-bye.
Thanks, Brian.
Thank you.
Bye now.
We'll move on to item 15.2, and this will be on population health. But before we start it, I just want to introduce the fact that this is going to be an application platform that's available to our board for education reasons. I think both Harry and Ted and Martina have been able to view it, and our governance committee will be looking at it as well to plan out our education using this platform. for the future. It has speakers from locally, but more so nationally. So when we're talking about national trends in healthcare, what other boards nationally are doing. So I think it'll be a great boon for our education. And with that, Martina, can I turn it over to you to start the video? It's a short one that usually lasts like 10 minutes, and there might be a series on a particular subject. And this one is on population health.
Welcome, Dr. David Nash, the founding Dean Emeritus of Jefferson College of Population Health. David, how are we doing today?
I'm doing great. Thanks for having me on.
It is an absolute privilege to be sharing time with you. And I say that because you, as we understand it over here at iProtein, are a rock star when it comes to the space of population health and population health management. I mean, you've been repeatedly named by Modern's Healthcare list of one of the most powerful persons in industry. You've published innumerable articles and helped edit, dozens and dozens of books, and you are widely recognized as an authority in population health. So we want to kind of dig in over the next few minutes on this very important topic. Why is it so critical? What's going on?
So, first of all, my wife still tells me to take out the trash, so, that's key.
Okay.
So, where's population health? Why is it so popular today? So, we've been thinking about these issues for more than 10 years now on our campus, and, kudos to the leadership at Jefferson, our enterprise CEO, Steve Klasko, our provost, Mark Tikashinsky. I mean, they were the leaders who continued to support the creation and implementation of new courses and really continue to support our college both locally and nationally. So Jefferson's been a great place to create this. And as you'll be aware, there are now more than a dozen other colleges and schools of population health and 40 medical school departments of population health. So how come today is the question. Well, why? I would say finally. I think how come today? Because we've come to recognize that it's not all about coming to the hospital to get care. Quite the contrary. It's all about what we've come to call the social determinants of health. Mm-hmm. And that in our great country, things like poverty, things like where you live, your credit score, your level of education, all these social determinants are the real drivers of health, or regrettably, the real drivers of not having good health. Yeah. So population health is a recognition of where we are in our society today. Obamacare passed March 2010 gave sort of a rocket booster to our interest in population health management. So taken together, recognizing those social determinants, recognizing the 10 years now of Obamacare nearly, together, that's really given a lot of emphasis to looking at the health of the overall population.
Yep. Yeah, and I recall you're saying in one of your earlier works a phrase that when your zip code is a greater predictor of your well-being than your genetic code, we have a real problem. So tell us about this problem, because, as a nation, we're north of $2 trillion in annual spend and 10,000 per pro rata per individual in healthcare dollars outlaid each year by each individual. Yet as a nation, I think you've said we're towards 20% of our total GDP. Talk about that.
Yeah, so here's the sad calculus. So we're spending roughly $3 trillion, 18% of the GDP. The real question is, what are we getting for our investment? And very regrettably, when you look around the world with data from the OECD, the Organization of Economic Cooperation and Development, our country doesn't rank in the top 10 of any sort of important global measure of health. So it's a sad reality that we spend the most, and you're right, roughly $10,000 per person, including children. And what do we have to show for that investment? If you couple that with the other epidemiologic disaster, which is that because of the diseases of despair, we're seeing a decrease in average life expectancy, especially for the millennial generation. This is like if you would, a 1-2 knockout punch. Mm-hmm. And it's a sad commentary on where we're going.
And then the other piece, I'd imagine, if a dollar is going to the healthcare piece and that's growing and we're not getting the yield out of it, that's a dollar that we're not being able to use for elsewhere. The other. Right.
You bet. You bet.
The 80% of the economy. Okay, so what do we do about this? I mean, clearly there's huge issues of waste, and I know you've written and spoken at length about. Tell us a little bit about the types of waste that are being produced, and how we can go about addressing that from the point of view of the hospital, and specifically, of course, our key audience here, board leadership,
you bet,
and management.
So we should add that I feel the pain of our board member colleagues, because I've been a hospital board member for 20 years, 10 years at what was Catholic Healthcare Partners, now Mercy Partners, Bon Secours Mercy, and another 10 years at Mainline Health, so a national Catholic system and a not-for-profit regional system. So, and I chaired the board committee on quality and safety as the inaugural chair in each of the two institutions. So, you know, I get it. So from a board perspective, look, if you believe the literature, and I have every reason to do that, $3 trillion, most experts agree, 1/3 of it is of no value and potentially even dangerous. So how do we categorize that 1/3?
No value meaning just outright.
Yeah, so let me tell you how we categorize the 1 trillion of waste. The 1 trillion of waste comes in typically sort of three flavors. Individual waste, bad behavior, alcoholism, depression, suicide, opioid abuse, obesity. The second type of waste is the experts call operational waste, waiting time, implementation, failure of the electronic medical record, and all the rest. And then the most important from my perspective and from a board perspective is clinical waste, which is a nice way of saying two things: medical error, really important, that's a type of waste, and unexplained clinical variation, which is another way of saying doctors do what they're trained to do, and with very little regard for closure of the feedback loop, getting data on their own performance. So let's sort of summarize three types of waste. Individual waste, bad behavior leading to illness. Mm-hmm. Operational waste, the day-to-day complexity of working in the most complex organization, of course, that Peter Truckee could find was a hospital. And number three, clinical waste, which includes medical error and unexplained variation. You know, this is how we do it here. Trust me, I'm an expert. So when you cobble those three things together, you're talking about $1 trillion in spending. From a board perspective, imagine if we could just, you know, on the margin, tackle each one of these and get a 5 to 10% improvement. That would be pretty helpful, and reallocate those resources.
Okay, so let's drill down a little bit into that. So I'm a board member of a rural hospital somewhere in Idaho.
Yeah.
And we keep reading and hearing about this very important subject of population health and population health management. Where do I begin? I mean, at the risk of sounding, it feels so overwhelming. It kind of, I liken it to how we might look at some of the global environmental problems, right? How can we create stakeholder mentality at the smallest common denominator, if you will, and begin to take a step into driving change, to say that we are being responsible agents for change in the mission for a better pop health initiative program?
Well, quite frankly, it's difficult to give advice for a 40-bed rural hospital. Okay. I mean, you know, I think let's look at so there's 5,000 community hospitals in America. Their average size, 250 beds, let's say. I think for those hospitals, they have to look in the mirror and kind of ask themselves, what is the mission that we're really in? If the mission is to improve health, well, by every measure we have available, we're failing. So what we talk about is going upstream to shut off the faucet rather than mopping up the floor at the end. Let me give you some examples there, please. I think most board members totally get their head around. So look, while we build another cardiac catheterization lab, what we really ought to be doing is talking about nutrition, exercise, bicycle lanes, walking more during the workday, getting the fryer out of the hospital cafeteria, those sorts. But instead, we're building another cath lab because, that's what boards do. They're there to invest in infrastructure, leave a legacy, increase market share. Yep. Our incentives are upside down, and this is a gigantic problem from a governance perspective. Yep. So boards have to set the moral tone and the moral authority about what's the mission, what are we here to do in the first place? Right. With all due respect to our colleagues at a 40-bed rural hospital, I get it. It would be very difficult for them to engage in any kind of pop health strategy the way we're construing it here.
Okay, but for the average 250, and there's 5,000 or more.
They have a real role.
Right. And can you speak a little bit about this this idea of from volume to value and how that kind of laces into all of this?
Sure. So, of course, we're not the folks who coined the term going from volume to value, certainly not. But I think our take on it is, well, there are key sort of strategies in the road from volume to value, and some of them we've already discussed. I think one is recognition of the size and scope of the waste, because as Don Berwick and many other experts have repeatedly said, you cannot fix the problem of the cost of care by focusing on the cost. You can't fix the problem of cost by focusing on cost, because anybody could reduce costs. That's easy. Close a program, close a hospital. What we're saying is you got to reduce waste. Well, to reduce waste, boards have to understand the three categories: per individual waste, operational, and clinical. So I think from a governance perspective, the questions on deck about reducing waste are, are our physicians trained and have additional opportunities to close the feedback loop with good data about their own performance and even measure that performance against a regional or national benchmark? And do we have leaders who can help close that feedback loop in a non-punitive way at the local level by giving doctors that good information about their own performance? My 30 years of experience tells me if you give docs good information that's severity adjusted, timely, non-punitive about their own performance, they'll stampede to improve.
Got it.
So that's one area. Second area is the education of everybody about the tenets of population health and participation in some of the bundled payment initiatives to practice what it would be like to be at economic risk for clinical decision making. This is all part of population health.
Is this the no outcome, no income?
Okay, well, I'm glad you said it. Yeah, so we've coined the term no outcome, no income. To us, that means exactly that you're only going to get paid when you have achieved the measurable outcome. Now, maybe you'll get paid less, but no outcome, no income, I think, is a pithy, easy way to understand, really describing the road from volume to value. They're very closely aligned, obviously.
Yeah, and this is clearly predicated on the faith and the certainty, really, around the data to be able to use the data to measure, to have trustworthy, reliable, measurable outcomes, right?
Yes.
That we can compare against other data to then get rewarded with the income.
Right. So what we talk about is the need for a registry. So I'm a primary care internist. I'd like to have a registry of my patients. So all the patients who have heart failure, diabetes, chronic lung disease, whatever it is. And I'd like to be able to ask, how am I doing with my population of patients? And then how am I doing in comparison to other practitioners? And what's my level of generic drug prescribing, readmission rate, medical error, sepsis, all the rest. So being able to give that data back to doctors to improve their performance, that's where we got to go.
Great. Okay. And more on that, stay tuned when we return with Dr. David Nash, our friend and expert on population health and health management. David, thank you for joining us.
Thank you.
Appreciate it.
Hey, well, any comments from our board?
Well, that was certainly thought-provoking.
It was a great one to start the board with in iProtein because of our interest in population health and what we're doing here. I was really interested in hearing that some of the things that we are already focusing on were brought up there, just in terms of looking at some of the waste with smoking and obesity and those issues that we are indeed working on those.
And we know from our community health needs assessment that we're already ahead of the curve just by the population that lives here. As we well know, a lot of people select to live here because they run, they hike, they ski, they bike, they're outdoors people. And as we noted before, we have lower rates of obesity and diabetes as a result than the general population. If I remember the results of that healthcare survey that we have taken in the past. So, always room for improvement, but aren't we? Am I right in assuming that we are ahead of the curve?
Does anyone want to have a comment on that?
Yeah, I think we certainly are. You know, I'm really curious to hear board comments first, you know, from it. But
yeah,
I heard kind of a challenge in that I want to be able to prove him wrong in terms of the 40-bed rural hospital that dismissing as making a change in their community. And I see that as a real challenge. We might not go from volume to value, but we can go from value to greater value. So, I saw that as a challenge.
Yeah, it's interesting. They divide it up into the three categories. So the first category has to do with improving the healthcare individuals give themselves. So that's probably educational and somehow trying to provide an understanding of incentives for good health. And I think we're working on that. Maybe we could do more. But the other component of that is behavioral health, which we are definitely at the forefront working on that. The second thing, the clinical challenges, you know, we have a lot of data that we looked at just even today when you go through the materials for our board meeting. I mean, there's a lot of data out there, but I don't know if individual physicians with their own flock gets feedback or that it is individualized to the physician's patient. So if I'm a doctor and I've got, 300 people that I'm sort of taking care of that are sort of assigned to me, I don't know if I get feedback on how they're doing in general. I mean, you do individually every year or often when you meet with them, but I don't know how you get comparative data on that. You could do it perhaps within the hospital where one physician's flock can be compared to another physician's flock and break down the various elements from readmissions to sepsis issues to frequency of visits, hospitalizations, things like that. But I think that's an area that we haven't explored and could perhaps think about.
Connie, do you want to make any comments? Any comments from our audience? How about you, Michael?
Chairman Wong, I just wanted to comment with what Director Barnett said. We do have a program called Ongoing Professional Performance Evaluation, where we provide report cards to our physicians and providers. We have had challenges at times with comparative data, but we do have reports, and we are in the process of refining them. Recently, we actually looked at a vendor that might automate that system for us. So we do have data. It's not as good as any of us would like, but we do compile reports for our medical staff and providers.
And how do they respond to that, Janet?
Yeah.
Well, that's why it's so important for it to be accurate. And that has been a challenge for us at times because, of course, we want to share accurate volumes and complications, infection rates, and such as that. And we have been challenged by that. And so we are in the throes of refining that process. And that's why we did recently look at a program that might help us. So how do they respond? I know Dr. Cole's on the line. She can answer that question. But again, they're open to the data. They just want it to be accurate and reflective. If we feel like there's an area for improvement, I work with the medical staff chair and the CMO and with the physicians on how we can improve any areas that we identify that need greater focus.
Thank you.
So I'll jump.
Oh, I'm sorry. Go ahead.
Oh, I was just going to jump in on Janet's discussion. So the physicians all want to know their data. We tend to be very competitive people, and we want the best data in the hospital. So we tend to actually really enjoy looking at that data. I do have to say, on a different note, what Janet's talking about is I can look at my C-section rate or my postpartum hemorrhage rate, et cetera. But Director Barnett, what you were talking about is, all my patients that I'm treating for diabetes, what are their hemoglobin A1Cs? And you actually can get that out of Epic. And I know our primary care committee has different ad hoc committees to look at colon cancer screening, looking at hemoglobin A1Cs, looking at all of those types of population health. So yes, we are looking at that, and we do like to improve our panel of patients' health in those kind of primary care arenas. You can't do that for an orthopedist who took care of somebody for one fracture care, but you can with the primary care.
Yeah.
Just maybe blending and building on Mary's and Dale's comments. I think we do benefit from being in a really unique environment, right? People self-select to be here, arguably a little bit healthier than your typical population. But also when the call out to the 40-bed rural health system, again, I think we're in a very unique environment. When I visit 40-bed rural health systems in Northwest Alabama, it's a very different situation than what we have here. And so I think that we do have an opportunity to be a leader in this, to be a beacon, to even share what we learn with other health systems, right? So I think we could take all the benefits and the positives that we have in our community and keep building on that for sure.
Challenge accepted.
Yeah. Just a question.
Through our hospital system.
Yeah, a question if I could. How much influence does a primary care physician have in changing the social determinants of health? I go for an annual physical, but I've never had the doctor tell me to quit smoking because I don't smoke. He's never commented that my BMI is too high because it isn't too high. I mean, do primary care physicians really have a measure of influence on something other than just stitching them up or fixing a broken leg or I'm just curious because I guess I don't know from my personal experience.
Oh, you're way too healthy, maybe we could say. But I do know that for some of the colleagues that I have and friends who have gone to the physician with problems, whether it's respiratory or smoking or obesity, that they are really, a relationship is built and a trust is built, and they have worked on some of that together. And there has been some incentive to do that based on the fact that they're going to go back as a follow-up. So I do really believe that there is an opportunity for every physician to make a change, and it might be one patient at a time, but they can make that change. Any other comments?
This is more of a question than a comment, but there's been a lot of discussion about preventive care, and I know the Medicare program provides a annual visit that's about an hour long, and it's to evaluate the patient's condition as opposed to a patient going in for a particular problem. And I remember Kaiser used to talk about its preventative care programs. I'm wondering how that ties into these concepts. I mean, it seems like it relates to the point number one, where people are not taking care of themselves. The second thing is clinical waste. That means how efficient is our system in getting the patients in and having them seen timely. And I know we've had discussions to try to address that. Might be more we can do there. And then here's my question, maybe provocative. Are we wasting our time with the so-called preventive medicine? Is that preventing the problems from coming in? And should we be doing that with our physician time as opposed to maybe some other type of programming? So that's a question I raised.
Director Barnett, it's Scott Baker. I can provide a little color to that if that's all right.
Yeah.
What the studies have shown is that just going in to see your physician every year does not necessarily have a heavy influence on outcomes. The annual wellness visit is a good attempt, but as you may know, it's relatively limited in its scope. And what the studies have shown is those who come in for regular checkups with providers and systems that have very strong care gap closure and preventative screenings do prevent a lot of poor outcomes and have much better outcomes. There's been a lot of studies out of the systems that do the shared savings that have a financial reward for having better outcomes and better long-term care. And some of those screening tools they use have very strong influence over the outcome. So it's not just going to see the physician every year, it's having the programs that ensure that those annual visits lead to those annual screenings at the right ages and circumstances.
That's an important answer. Thank you.
Any comment from our board on the use of iPro or iProtein as a learning ability?
I'm very excited about it. I think this was a good start.
I think it's very thought-provoking and very good for us.
Again, it was an introduction to population health. It was part one. So we might have seen what the problems are, but we'll see in the other ones some of the solutions that other organizations have used.
I just, one last comment, I just want to share that, in my 6 weeks here, I've had a lot of conversations with Maria and Janet and others that do just a fantastic job in terms of what they're trying to do. And they continue to bring up innovative ideas. And I will say that this community, I think, is very unique in the way, in the offerings that we already provide. But but they are encouraged by continuing to do more. So I think that there's just a lot of opportunity here for us with an already active population, a population that's already engaged in their own healthcare and want to be a healthy community, and then just some extremely talented, smart individuals here at the health system that continue to promote it. So I'm encouraged.
So one of the challenges, obviously, was establishing a patient registry. And I think, Janet, you commented on it. How far away are you from coming up with something that's real meaningful that would challenge the doctors in a non-threatening way? Is it around the corner?
You?
I don't know. Is Janet still there? Maybe not.
Oh, I'm still here, Dale. Sorry. We are every day working on it as far as programming, through Mercy Epic to access this data so we can share it with our providers. Working with Dr. Cole and Dr. Taylor, who's our quality medical director, on the metrics. We are very close to our next, shall we say, rendition of that summary report that we will be sharing, again, first with Dr. Cole and Dr. Taylor, and then roll out to our physicians. So I don't have an exact date, but we are getting closer.
And do you agree with that individual that spoke to us that it can be presented in a non-threatening way that does challenge them?
Oh. I believe so, but I'd love for Dr. Cole to comment. But absolutely, as she said, doctors are they love data, and they are competitive. So especially if we compare them to their colleagues, it can motivate them even more. But Dr. Cole can comment also.
Okay.
Thanks, Janet. Yeah, I totally agree.
Right. Yes, I've seen in many hospitals where the data is shared, and the great hospitals do it in a non-threatening way. And, it's nice to have a tool like Epic to begin to gather data. We're still a little bit disadvantaged when you contrast us to, like, I'm just going to give you a Reno example. There's Prominence Health Plan and there's Hometown Health, or nationally you have Kaiser or Anthem. And in these 4 examples that I gave, they're able to really bundle together and look at all the types of care that patients receive, because guess what? All the claims land in one bucket, and they can look at all the diagnoses and the cost of care and so forth. So that phenomena that can happen in busier urban areas, and that's one of the reasons why I think he was a little bit reluctant on the rural 40 hospital, is that 40-bed hospital is it's really difficult for almost any rural town, rural hospital to have the big capitation models where we really see all the claims. We only see the claims for care relative to the times that they touch us, which might be 100%, it might be 50%, it might be 20% of the care that those patients are seeking. But I think these goals of promoting wellness, they talked about the individual, the operational, and the clinical, really encouraging people to optimize the individual. And really our strategic plan that we have for the next 3 years, I think really drives us, pushes us to look at all 3 aspects, the individual, the operational, and the clinical, and to make relevant improvements for us. For example, I attended a Anthem hospital relations meeting the other day, and it's easy to develop a health score if these are all insured individuals who are employed and the families have houses and food, so there isn't housing insecurity or food insecurity. But if we were to try to create a health score that had to take into consideration no housing or no food security, the elements become a lot worse. And that is the population that we treat, in our rural system, and certainly it happens in county systems. You probably will see health scores. Again, Anthem wants to do it. Purdue Farms on the East Coast did it for all their employees and dependents. I think you will see this a lot more as there becomes an interest that we must slow down the cost. Like the speaker was referencing around $3 trillion in total cost. Well, he's a little bit dated. I have the sheet from me from CMS right now from all payers. 2012 was $2.8 trillion. 2015 was $3.2 trillion. 2022 is $4.45 trillion. And 2028 is $6.2 trillion. So currently in 22, per CMS's estimates, healthcare costs $13,261 per year per man, woman, and child. This is like a rocket taking off, when we were at 1 trillion back in 1998. So yes, as a citizen and a taxpayer in America, I have a deep interest in seeing how we can help people get well and slow this down. Because if you ever read the Secretary of the Treasurer's annual report on the U.S. government, there's about 100 pages of risks there, that can harm America. And this rocket increase in healthcare costs is the number one concern that's been stated several years in a row. So our system is deeply committed. I think we are starting to get some data for docs, but I think some large elements that are really important that we can, be joyful about, but we want to improve on, is our admits per thousand population. We're down about 40% below the statewide averages. Our ER visits really aren't that high per thousand population, and our ER visits and inpatient census have been flat over the last 6 years, while everything else has gone through the roof. But it does save on healthcare dollars. There's such huge motivation, when I've talked to capitated hospital systems, whether they're in Pennsylvania or Albuquerque, they have incentives to admit to home versus to a hospital, to provide at-home monitoring devices, because they're paid per member per month, whether they actually provide any care or not. So all of the good efforts that our health system is committed to do, and that's in our strategic plan, we're not going to get paid a dime for avoiding an ER visit or avoiding an inpatient admission. Yet we as a team believe that's the right thing to do for our community. And I think we're doing it better than most systems, but we can't rest on that at all. We still have a lot of work to do going forward. So this was part A tonight. Healthcare is a big topic that America, in the sickness industry and everything. And there's a book written, Wellness, the Next Trillion, by Paul Zane Pilzer. It was written several years ago. And I invite you to read about that too, as we're really starting to look at this. But I think this one in part 2 will be helpful. And I'm just glad to hear each of you guys talking about it as you are, and hopefully we'll feel comfortable with talking about it a lot more in the future.
Thank you, Harry. And again, this was just part 1. I know we've got population health is included in our strategic plan. So we will be monitoring and looking at both what we're learning on iPro and what we're doing in real life, and see if we can make a difference. Again, I think we have to focus our energy on what is our highest priority, because we don't necessarily have all the time, all the resources, and all the people to do a lot of the work. And I know right now our health system is being stretched with the staff that they have. So again, it's something that we can aim for and hopefully make some improvements as we go. Any other comments from our audience regarding iPro or population health? Okay. So the board will be getting some direction on how to use the iPro as an individual and what things that we will bring to our meetings to share as a group. Okay, then we'll move on now to items for the board action. And our first one is Resolution 2022-07. And Harry Weiss, our President CEO, will present this resolution to update the Board of Managers of the Truckee Surgery Center, LLC.
Good evening, Chair and members of the board. We do need to refresh this document which guides who are the board members for Truckee Surgery Center. And as Judy Newland is retiring, we need to replace her with Louis Ward. And I think that's really the main change in this document this evening. We ask your approval and consideration on.
Does everybody understand what we're doing with the resolution? It's a matter of changing names, but starting to eliminate names and include positions. Is that correct, Harry?
Yeah, I think that, Dr. Dodd is a 1% owner, but we really needed to update the document primarily due to Judy's retirement and Louis joining our health system. So it just clarifies basically who is the revised Board of Managers for Truckee Surgery Center. I chair that Board of Managers, and then historically we had Judy, Crystal, and Dr. Dodd on, and now we need to replace Judy.
So is the motion to replace Judy with another person, or is it a
resolution?
We have I think a resolution that states.
Yeah, it would be a motion to approve Resolution 2022-07, which elects the COO to the position held by Judy Newland.
Right. So we're just asking for your review, consideration, and approval of this specific resolution.
The operating agreement for the LLC previously identified the Board of Managers by name, and so this change will have it identify them by title with the district.
It becomes less stale. I should have said it that way.
All right, then I will move that the board approve Resolution 2022-7.
I'll second. Dale?
Okay, so it's been moved and seconded to approve the resolution to update the Board of Managers of the Truckee Surgery Center, LLC.
Assuming no public comment.
Yeah, sorry. Is there any public comment on the resolution? Okay, seeing none. We've had it moved by, no, I've forgotten that.
Director Barnett.
Okay, Director Barnett and
second by Dale.
Director Shamlin to approve the resolution 2022-07. A roll call
Director
vote.
Barnett?
Yes.
Director Shamblin?
Yes.
Director McGeary?
Yes.
Director Brown?
Yes.
And Director Long?
Yes. The resolution has been approved as presented. We'll go to item 17, and we had pulled order and decorum, which was 14.6.1 for discussion. And Ted?
Chair Long, I'll take that. Each year, order and decorum comes before the board in your annual retreat for any modifications and or changes. It is then brought back to you for adoption. This year, the draft in front of you was heavily marked up by the expertise of the attorney on the board, Director Barnett. And so you have those changes. And I did receive comments from Director Chamblin and Director Long after the posting. So I can walk you through them or I can discuss them with you. The first one was a numbering change in the draft, which has been corrected. The other was the change of the word in 1A for members of the public to address the board from the lectern rather than the podium. And that has been changed. Thank you, Martina. And that has been changed. And the third was under board vacancies, second paragraph, calling did not have an A, so that has been corrected as well. And under culture, it was called into question. At one point, we used president and CEO, and then later in the document, it just referred to the CEO. And for consistency, they have all been changed to president and CEO, as you can see there. So those were. Go ahead. I see, Alice, you want to say something?
Did you change all the numbering? Because remember that the first part, if you can scroll up, it was numbered. And right here, it changes to lettering. Is that how it was meant to be?
I can answer that. The answer is yes, it's number 1. And then it says the following rules of decorum will guide participation in the meetings. Instead of numbering them, we used letters for the components.
That's right. But number 10 for culture, which wasn't numbered before, it's been numbered.
So can you scroll up further, Martina?
Yeah, go back to the beginning.
Yeah.
Yeah.
So we start with participation is number 1.
Yes.
Correct.
Okay, and then start scrolling down.
2.
2 is promptness. Okay.
Agenda.
Okay, so this is 5, 6, 7.
Okay.
8, 9.
8, 9. And so this is 10. And so all these are just subsets of 10?
Yes.
Okay.
And so those were the changes as directed by the board. So unless there are any other changes that you would like to make this evening, I would seek a motion to approve the document as it's been amended.
So is there any discussion about order and decorum? Because essentially we talked about the content at our retreat, and these are just some refinements after it was posted on our agenda.
That's correct.
Does the audience have any questions about the order and decorum? And because you have a role in it too. Okay, seeing none, can I have a motion to approve the order and decorum as revised?
I'll move to approve the order and decorum for 2022 as revised.
Okay. And I'll second, Dale.
So it's been moved by Director Barnett and seconded by Director Shamlin to accept the order and decorum for 2022 as revised. A roll call vote.
Director Barnett,
Yes.
Director Shamblin,
Yes.
Director McGeary,
Yes.
Director Brown,
With appreciation, yes.
and Director Wong.
Yes. So the order and decorum has been approved for this year by the board. So thanks a lot for Ted for doing those revisions.
May I make one comment? I wanted to thank the board. This is the most revisions that you've ever done in a year to order and decorum. It's meant to be that kind of a document that lives with you, and I wanted to thank you for your input on it.
All right.
One other use comment. We designed point number 1 in the A through G section so it can be separately posted either online for our meetings, or if we meet in person, it can be actually posted, so that participants walking in would be able to see what the rules are.
Thank you.
Great.
Could be a good practice.
Alice, just a quick point of order. I have difficulty hearing Ted. I can hear everyone else quite well, but Jake, can you get Ted a new microphone? Are all you having the same trouble hearing him that I am?
Yes.
Okay.
Who are you having trouble hearing, Dale?
Ted.
Oh.
Are you hearing trouble?
I thought he was just soft-spoken.
My hearing's good, and everybody else comes through bright and clear. But Ted sounds like he's talking through a wet blanket. And
I get him a microphone.
He'll work on that. So it's understood that he's going to work on it.
Okay.
We're going to move on to.
No, I'm not sure if that's in the budget, Jake.
Yeah, right. Would you fix that, will you?
What I have to scrap that.
Okay, we'll move on to 18, the board committee reports. Were any of our board committees meeting?
Finance is going to meet in April.
Okay, and I know the executive comp isn't meeting until later as well.
Right.
Yeah.
All right. So that will be the end of our meeting. I do want to welcome and thank Louis Ward as our COO. We'll be seeing you on a regular basis now that Judy's going to be enjoying retirement. So welcome.
We all hope that for her, and thank you, Chair Wong.
All right. Any other closing remarks? Okay, hearing none from anybody, the meeting's adjourned.
Good night.
Thank you.
Great.
Good night.
Thank you, Alice.
Good night.
Recording stopped.